Hello, everyone. Welcome to today's episode of The Doc is In. I'm Dr. Theodora Kerenidi. I'm a pulmonologist in Cleveland Clinic, Abu Dhabi. And joining me today is my dear colleague, Dr. Mateen Uzbeck. He's a consultant pulmonologist in our department, respiratory department in Cleveland Clinic, Abu Dhabi. So welcome, Dr. Uzbeck.
Thank you so much, Theodora, and happy to be with you today.
Thank you. So in the next few minutes, we will be exploring the asthma, RABU, and we will share some insights regarding the diagnosis and the management of this common disease. So my first question to you is it really common in our region in UAE? And what are the most common triggers of this disease?
So thank you once again for having me over and having this discussion. So it's a really important area, and we see a lot of patients with asthma every day in our clinic. Mm-hmm. And when we look at the prevalence of asthma, worldwide and in the region, the prevalence is quite high. There's estimates of the prevalence being somewhere around 15 to 30% in our region, in the Gulf region. And due to some unique climatic conditions, we have some unique triggers here, like the sandstorms, the humidity. But other than that, the usual triggers that we see are dust, exposure to fumes, some exposure to bahur. So these would be like kind of the common triggers that we would see for asthma in the region.
Oh, thank you for that. So in my clinical practice, I'm seeing many patients that they're coming to me first time, mm-hmm. and they usually asking, "Doctor, do I have asthma?"
Sure.
And my response to them is usually, "I'm not sure yet."
Yeah.
So do you face the same thing?
Yes, I think that's a very good response that you give them, because we can often misdiagnose asthma. But the important thing to know here is that asthma is very common, and the clinical features of asthma, such as coughing, wheezing, chest tightness, these are quite common to other clinical conditions as well. So, there's a saying that not everything that wheezes is asthma. So in the right clinical context, with these clinical findings, with these clinical with these things in the patient's history, such as coughing, wheezing, breathlessness, a history of maybe atopy or allergies, maybe a family history, we can sometimes tempted be to make the diagnosis of asthma, but we should, I think, refrain, and we should try to go for objective testing. And I think that's what you were referring to. Yeah. So what we can do for these patients is a very simple test called spirometry. And we are fortunate to have a very well set up PFT or pulmonary function test lab in our hospital. So a spirometry basically looks at the flow of air in a patient. We check something called FEV1, which is the forced expiratory volume in the first second. And then, because asthma is a variable disease, we check reversibility after giving a medication such as salbutamol to see if their lung volumes or the flow of air in that patient improves by some criteria, which is like 12% or 200 cc's. And if a patient has these symptoms, and they may often have normal lung function, so it doesn't mean that they don't have asthma. It just means that they may not be having those variable symptoms or that variable airflow limitation in that day. So you can always follow those patients clinically, and you can consider like more specialized testing, which we have in our hospital as well, such as a methacholine provocation or a methacholine challenge test. Or if that's not available or you're not able to do it, we can check peak flow variability. We have the FeNO, which measures the exhaled nitric oxide in the breath, usually not used as a diagnostic measure, but as a supportive measure to assess these patients and follow their progress.
This is very informative. So actually what I understand and what we are saying to the patient is that the symptoms, along with the variability that we have to document with some point
Sure.
in one of these tests,
Sure.
these together, combined,
Yes.
give us the diagnosis.
Yes, and we don't want to obviously underdiagnose asthma because that can happen, but we also don't want to misdiagnose or overdiagnose. And there's been some really interesting studies. I was recently reading an article in a medical journal about patients with asthma in Australia. So the physicians had diagnosed asthma over the years, and then after some time, these patients were reassessed, and they had formal testing. And actually, a significant number of those patients actually didn't turn out to have asthma. And the biggest factor was that at the time of diagnosis, they didn't have lung function testing. So if possible, in the right setting, we should try to obtain the spirometry or the lung function test.
And it's recommended to try to do this test even before starting to treat.
If possible.
Sometimes.
If possible, if that's a
if
possibility,
possible.
yes, sure.
And you mentioned, Dr. Mateen, about FeNO, which is one of the markers of airway inflammation.
Sure.
Are there any other markers that we can measure, and do you need them for the diagnosis at the beginning or later?
Yeah.
So how usually when you measure them?
I think that's where the future of asthma is going, and I think you're raising a really important point, which is that asthma is not one box that fits all. So there's different. We realize now that there is more and more what we call phenotypes of asthma, and all these different phenotypes have an underlying disease mechanism or an endotype. And for example, the sputum or blood eosinophils, the FeNO, the IgE. So these are all what we call biomarkers, and they reflect the underlying disease process. And at the time of diagnosis, sometimes it may be difficult to capture these, but if possible, we should for their future care, and especially patients who are not responding to treatment, patients with more on the moderate to severe spectrum, where you're thinking about, maybe starting them on more personalized treatment like biologic advanced therapies. That's where those biomarkers are more important.
Okay, so we can measure at the beginning,
Sure,
more to have a baseline,
sure,
maybe help us with the diagnosis, but they are not diagnostic.
They're not diagnostic. We shouldn't be diagnosing just based on them. Yes.
And I have patient. Unfortunately, patient feels like if their symptoms are on and off. That's a mild asthma, and that's not a serious disease.
Yes.
So they can just rely on...
No, I think I share the same type of patients as well, and it's always difficult to get the message across that, mild asthma, yes, it is sometimes a mild asthma, but mild asthma does not mean benign asthma. Mild asthma can still have what we call flare-ups or exacerbations. And these exacerbations can be severe. So it's really important to educate our patients about taking the right treatment. And I think one of the biggest kind of, I should say, not drawbacks, but maybe pitfalls in asthma care over the decades has been that, somehow patients feel better on taking this medication called SABA, or the short-acting beta agonist.
Or the blue inhaler.
Or the blue inhaler, well about that. So actually, it causes the patient to feel better by causing bronchodilation, but it's not treating the underlying disease mechanism, which is airway inflammation. So I think this is one of the biggest hurdles, one of the biggest challenges in patients with asthma, which is the over-reliance on the short-acting beta agonist, the salbutamol, the albuterol-like drugs. But I think there's been a recent shift in the way the medical community, the pulmonology
and
world,
the GINA recommendations.
GINA, as we know, is the global organization for asthma, for guidelines. And, there's a shift away from using SABA alone. So SABA should never be used alone, in fact. And now we have the SABA ICS inhalers, the short acting SABA combined with an inhaled corticosteroid, and also even in the general guidelines, the preferred recommendation is always to have a inhaled corticosteroid when you're using a bronchodilator, such as a fast-acting, for example, formoterol. That's the preferred, what we call the track 1. So those patients should always be on an inhaled corticosteroid. So there's a shift away from the SABA alone. Yeah.
So the take-home message for SABA is that never SABA alone, never
yes.
blue inhaler.
Yes.
So please don't rely on that.
Yes.
It's a good reliever, but just that.
Yeah.
And we already moved to the management of asthma.
Sure.
And we already mentioned few things.
Yes.
So just to make it a little more clear for our audience,
Sure.
How you start to treat a patient with asthma, based on what, and which is the most acceptable management for now?
Sure. So I think once we have established the diagnosis of asthma, you've assessed the patient, you've spoken to them about the disease, you've spoken to them about how you're going to manage the disease, then starting them on the right treatment is extremely important. And that's determined on a few factors, obviously the patient's acceptance, the patient's preference, but also what we highlighted about the airway inflammation, that it's a chronic inflammatory disease of the airways, so it will need some medication that may be needed for a longer period of time, which will need to treat the airway inflammation. So usually based on what we would call asthma control, or what we can even call asthma severity, we start the treatment which we feel will control that level or that severity. So if it's mild asthma, you're starting at a different step. If it's moderate, you're usually starting on a higher dose of the medications. So the preferred, we call them the tracks for asthma management. So the preferred track is to have a patient on a ICS, which is the inhaled corticosteroid, with a rapid-acting, long-acting beta agonist, which is the bronchodilator, such as formoterol. And this is the preferred track in which the same inhaler is their maintenance, meaning it is their treatment, and is also used as their emergency or as their reliever inhaler. So this is track 1. And then the second track, if, for example, this approach is not possible or the patients do not prefer this track, then the main message is that they should always be on an inhaled corticosteroid, and depending on the severity, the dose can be mild, medium, or high dose inhaled corticosteroid with a bronchodilator. And then as their reliever, they should never be taking the SABA alone. So the new recommendation is to have them take the combination ICS SABA inhaler if that's available. If that's not available and it's only SABA, they should take an ICS anytime they take a SABA. And then as you go up on the steps, then you're obviously adding, other agents such as long-acting antimuscarinic agents, the LAMAs as we call them. And, these can be individually added, or they can be added in a single inhaler as a combination of what we call the triple therapy now. And then this is the stage where, you're heading into the severe asthma spectrum of things. But yeah, in a nutshell, kind of this is the management, and then you're obviously bringing the patient back for assessment. You're making sure that their asthma...
How often you are usually...
So in my practice, I can go anywhere from 2 to 3 months, bringing them back, assessing their what we call asthma control. And if we feel that they are well controlled on this therapy, I can maintain the same course, or I can start to reduce the treatment, and vice versa. If they're not doing well, I'll be stepping up the treatment.
So it's not like we give one inhaler to somebody and this is what he will continue for the rest of the life.
Yeah, I think that very rarely happens, but we should be, seeing them periodically, repeating their lung function, make sure that we're not seeing any big drops in their lung function tests, and looking at, I think you mentioned comorbidities, looking at other, because asthma can also occur along with other disease processes such as allergic rhinitis, gastroesophageal reflux disease, obstructive sleep apnea, psychiatric illnesses. So all of those, need to be managed as well to have good asthma control.
Yeah, so sometimes the asthma control will not be good, not because the patient, the medication that we are giving to the patient are not enough, but there are other things that are going on, like you mentioned, the comorbidities that
Sure.
we need to address
Yes.
so that we have a better control of the asthma.
And I think that's really important because sometimes patients get labeled as severe asthma, whereas it's actually we're dealing with what's called difficult to control asthma.
Yeah.
So looking at those patients, stressing on the comorbidities, making sure they're taking the inhaler technique, those things are really important. And then a small percentage actually do have severe asthma. So it's estimated around 10 to 15% of asthma. It's still quite a lot of patients. If you look at the millions of patients in the world who have asthma, a significant number have severe asthma as well.
So there's no difficult patient, but it could be a difficult asthma to treat.
Yes, absolutely.
Absolutely.
Yeah.
So as you mentioned, it's very important to differentiate between difficult to treat asthma and severe asthma.
Sure.
Because severe asthma is, as you already mentioned, is the one that we need a more personalized treatment, and there where we think about biomarkers. And now, in these last few years, we have all these biologic agents that probably it's for this step of severity of our asthma patient.
Sure.
So could you please tell us a little about these biomarkers, which biologic we have now, and what we can offer to our patients with severe asthma?
So, if you look at the trajectory of, asthma treatments over the decades, back in the 60s and 70s, we only had salbutamol, then the inhaled corticosteroids came. So we've come a long way. And if we look at the biologic therapies or the more advanced therapies, so we've had omalizumab, I think came out back in 2003, 2004. So this is the human monoclonal antibody that targets IgE. So it was used with good effect in people with the allergic phenotype of asthma. But, we have now realized and we are understanding the pathophysiology, the inflammatory pathways that drive asthma so much better, that we have a more in-depth understanding about all the phenotypes and all the endotypes in asthma. So we've identified, these inflammatory targets that are driving the asthma and the inflammation in asthma. So we know that there is the type 2 high asthma, as we call, which is predominantly driven by the eosinophilic processes. And we know that there are biologic agents such as anti-IL-5, there's anti-IL-5 receptor antagonist, there's anti-IL-4, which also blocks which is also anti-IL-13. And now we have the newest or the latest one is the anti-TSLP, the thymic stromal lymphoprotein blocker. So these are all the biologic agents that are blocking these cytokines, as we call them, as which are driving the inflammation in asthma.
So different cascade of the inflammatory process.
Yes,
Okay.
and then obviously some patients don't have these markers are the non-type 2 type of asthma. And in those ones, we are seeing that the evidence for anti-TSLP is good in those, and those patients are responding. So these are the kind of latest developments in the biologic agents.
So based on the biomarkers, comorbidities,
Sure.
if the patient are on oral corticosteroid or not,
Yes.
then we can decide which is the best biologic for our patient.
Yes.
And start on that.
I think that's really important to have like like you said, have the biomarkers available. So the eosinophils usually above 150, elevated FeNO over 20 parts per billion. And we're also looking at the IgE. We're also looking at their, allergic profile, their atopy profile as well. So these are kind of markers that then help guide us along with the presence of certain comorbidities. And then obviously we look at the efficacy of these medications based on both clinical trials, real world studies, which show the efficacy of different biologics for different types of asthma with different comorbidities.
And now it's first time in our in respiratory disease that we are talking about remission. Remission usually
Yes.
goes from rheumatology,
Yes.
our oncology
Yes.
colleagues.
Yeah.
So in asthma now we are talking about remission, which are patients that we are giving the biologic, and if we follow them for 1 year, then we need them to be with a good symptoms control.
Yes. Mm-hmm.
Patients without oral corticosteroids for this period of time, no exacerbation, which is very important,
Yes.
and a normal or at least their best lung function.
Or improving lung function, stable lung function.
So
yes.
in this case, if you have a patient on biologics and they fulfill this criteria, they're doing well, this is a patient on remission. And this is what we can achieve pretty much on 30-40% of our patients.
Yes, I mean, it's an emerging concept, like you said, for our patients with asthma, the severe asthma patients, and clinical remission. And we're even taking it further to look if they're having, biologic remission, and, what's happening with the inflammatory markers in these patients. So, yeah, it's exciting times, like I said, for our patients, and I think we have a way to go before we can start implementing, the concept of clinical remission, even maybe earlier in the disease. Even patients who have, milder and more moderate asthma, we should be maybe considering
with less severity.
Exactly with getting them into a kind of state of remission with no symptoms, no reliever use, no exacerbations, improved or stable lung function.
And these are patients that they need, more dedicated clinics, and these are the patients that our colleagues should refer to centers.
So I think we are really blessed, and we are really fortunate to have a great team, because severe asthma clinics, they're always a multidisciplinary effort, because we're not only looking at asthma, we're looking at the comorbidities, maybe we're looking at more the immune profile of these patients as well. So having the severe asthma clinics where we have access to not only pulmonologists, but maybe immunologists, ENT colleagues, psychologists, respiratory therapists. And one of the important things really is also the nursing care. So we also have our nurse-led asthma education clinics here at Cleveland Clinic Abu Dhabi, and I think they do a very useful job to not only educate the patients, but also check their inhaler techniques, make sure that they're using the medication at the correct time, and also give them an asthma action plan. So when they're going away home from the clinic, they actually have an asthma action plan to know if their disease is stable, what to do, if the disease is progressing, what are the actions they can do, and obviously to identify life-threatening or emergency situations. And that's where the asthma action plan and the nurse education is really important.
Yes, and we always say that in asthma management also the education is
Yes.
a big part of what we should do and how we can help our
Absolutely,
patients.
and it starts from the first meeting you have with your patients.
Absolutely.
And educating them about what is happening, getting them on board, explaining to them what the likely course of the disease will be, and that they require regular follow-up. And I think that's really important to set the expectations right from the beginning.
Absolutely,
Yeah.
absolutely. And what about non-pharmacological? There is anything that
So
we can
I think,
offer?
so I think some things are very standard, like smoking cessation. Obviously, that's key if you have asthma and you're smoking on top of that. And it's not just smoking, it's the use of electronic cigarettes, shisha, midwah, all of those things. They need to be offered, a cessation program to try to get them to stop smoking, or what we call a tobacco cessation clinic. So those are important. Then obviously avoiding the triggers for their asthma, providing them with the vaccinations that they require.
Perfect.
The yearly influenza. Now we have RSV vaccine as well, the pneumonia vaccine. So those are really important.
Thank you.
Yeah.
And AI is here, it's everywhere.
Yes, yeah.
So any comment?
Yes,
Is there any implication of AI in
Yes, I think
asthma?
I think the other day you were showing me an interesting overview of AI, and AI is being implemented now in all fields of life. So for our asthmatic patients, really the benefits are remote tracking, the artificial intelligence prompting the patient to use the correct medication at the correct time, helping the physicians track the medication use by the patients. And also, I think in the future, AI is going to be very useful in the diagnosis of the patient, in helping identify patients who are at risk for a certain disease, and getting those patients on the right treatment, early on in the history of the disease.
Oh, this was very fascinating.
Uh-huh.
So thank you very much, Dr. Mateen. I think this was a very valuable insight and discussion.
Yeah.
Thank you for watching us today, and please visit clevelandclinicabudabi.ae if you need any more information about asthma and our clinic. Thank you very much.